Hello, everyone, and welcome to Spine Talks, where we bring unparalleled access to world-class experts like the doctors who are joining me today. Today, we're going to be talking about bone health and men. Oftentimes, this is an overlooked condition, and so I'm going to turn it over to start with an introduction from Dr. Anderson, and then we'll have Dr. Elder introduce himself, and then we'll get into some questions about general topics around what men need to think about when it comes to their bone health. Dr. Anderson?
Yeah, hi, I'm Dr. Paul Anderson. I'm an orthopedic spine surgeon from the University of Wisconsin in Madison, and am a co-chair of the National Spine Health Foundation on osteoporosis.
Thank you.
I'm Dr. Benjamin Elder. I'm a neurosurgeon, spine surgeon at the Mayo Clinic in Rochester, Minnesota, and I'm a member of the task force with National Spine Health Foundation on bone health.
A lot of times people think that bone health is not something that they need to think about. Osteoporosis is a disease that affects our bones, and we think about osteoporosis as something that affects really only women. And osteoporosis is often called the silent disease because you don't really know about it until you really know about it and you have a fracture. I'm going to start with Dr. Anderson asking you a simple question. What is osteoporosis, and do men get it?
Well, osteoporosis is the decrease in your bone mineral density, that is how much calcium and other minerals are inside your bone, as well as how these minerals are structured in the bone, that leads to increased bone fragility that is much more likely to break, resulting in an increased fracture risk. And although we see it much more commonly in women, osteoporosis does occur in men, and about 1 out of 4 people with osteoporosis are actually men.
And Dr. Elder, as a spine surgeon, do you see a number of men in your practice that come in for spine conditions that have osteoporosis?
Absolutely. As Dr. Anderson said, it's traditionally thought of as a disease in women, but it occurs very commonly in men, and specifically in the spine surgical population. We see it in not quite equal numbers, but more about 1/3 men versus 2/3 women. And so it can be a significant factor for both populations.
And Dr. Elder, when you see those patients, do they tend to be across all age groups, or is it really something that's just for older men? Talk to us about that.
I mean, we do see it across all age groups, but it tends to be older men, at least above the age of 50, and typically 60s, 70s, 80s. It's far more pronounced in men over 70. It's a little bit different in men because women have a big effect from going through menopause on their onset of osteoporosis and the lack of estrogen production, whereas men have more stable hormone production throughout life, although that does taper off as you get older. And so we do see osteoporosis as men are generally older.
So men get osteoporosis. You're seeing it in your clinics. Let's talk about how it gets diagnosed for men. Dr. Anderson.
Well, this is one of the disparities in medicine where women are much more likely to undergo bone health assessment with testing such as DEXA than men. In fact, if you look at preventative strategies for preventing fractures, men are screened for osteoporosis only 1/3 as likely as women. But the evaluation of a male is very much the same as for a female. They would undergo diagnostic testing with certain laboratory tests, as well as bone density measurement with a test called a DEXA scan, and also assessment for lifestyle factors, as well as various comorbidities, that is, medical conditions. And what we oftentimes find in men who have osteoporosis is there are serious underlying medical conditions that may or may not be even diagnosed that are leading to their fractures. I would add to what Dr. Elder said that although the patients are over 50, typically, we do see in younger patients than 50, but these are patients who generally have really serious medical conditions, such as they have transplants where they're on a lot of medicines that cause osteoporosis, or they may have inflammatory conditions like rheumatoid arthritis, or a condition much more common in males is ankylosing spondylitis. And these medical factors lead to men getting osteoporosis at a much earlier age.
And it's actually, I totally agree on that point. And the same risk factors for women are also applicable to men. So as Dr. Anderson suggested, some of the long-term treatments like high-dose steroids that patients with transplant or rheumatoid arthritis might take, smokers, alcoholics are far more likely to have osteoporosis. And that's true for both sexes.
And when it comes to seeing a spine surgeon for back pain, when you're evaluating patients, and let's say a patient might need a surgery and you're trying to decide whether or not a surgical intervention is the right treatment pathway for them. When do you decide to check their bone health? When is that a consideration?
Well, so for me, I investigate all patients that might undergo spine surgery with instrumentation and check them for their bone health. I find probably about a third of my female patients above the age of 50 come in with a recent bone density test, maybe up to 50%. But definitely less than 10% of the men have ever had a bone density test checked in the past. And it may even be less than that, as I can probably count those on my fingers.
Yeah. I think one of the important things we're saying here is that a DEXA scan is a bone health test. It's not a test that's just for women. It's a test to measure your bone strength and health. And I think that's something that's very fascinating, that more women are getting DEXA scans than men. And maybe we need to think about changing the educational messaging about that. Dr. Anderson, what are your thoughts on that?
Well, I can't agree more. As I mentioned, there's a disparity in diagnosis and treatment of osteoporosis in men versus women. The recommendations of the U.S. Preventative Health Service Task Force, as well as various other bone health organizations, is that the men over the age of 70 prior to orthopedic and spine surgery have a DEXA test before their surgery, but also those who have significant risk factors, like we already talked about, should undergo bone testing as well. And this also has to be balanced against the magnitude of the operation. We can do very small, minimally invasive procedures that are outpatient, take less than an hour, and those patients were not as worried about bone-related complications from osteoporosis, versus we can do operations that involve 10 hours of surgery and putting 20 screws in someone's spine and fusing their entire spine. Those patients, we are critically concerned about osteoporosis, and both for men and for women would need a bone health assessment preoperatively.
Although some of those small surgeries in the setting of osteoporosis can quickly turn into a big surgery when there are complications. So it's definitely a strong consideration for everyone.
That's so interesting. Let's talk a little bit about vertebral fractures. So there are patients that need surgery whose bone health should be tested, whether they're men or women. Let's talk a little bit about fractures that occur in the spine. And do those fractures occur in men, and are they osteoporotic? How do we think about that?
Oh, absolutely. So the one method to test for osteoporosis is, of course, based on the DEXA, but having a fragility fracture, which means a pretty low energy fall or any sort of low energy trauma where you develop a vertebral fracture or compression fracture, and that's also applicable for a hip fracture, is diagnostic of osteoporosis.
Can we say that again? Let's say that again. That is so important. And a low intensity fall. Let's let everybody know what exactly we're talking about with that.
Right. Any sort of fall. So if you're in a major car accident and you have a fracture, that's one thing. But if you just have a trip and fall on the ground from a standing height and end up with a fairly severe fracture, that's a sign that your bone is not strong enough to support life. And even a lot of patients show up, don't even know they have a fracture, and can't remember the last time they had any sort of traumatic injury.
So, Dr. Elder, let's underscore that point again. A low intensity fall. What exactly are we talking about with that, and how is that different than something more traumatic?
Right. So there's a big difference between a high impact car accident, where you can certainly have major life threatening injuries, and tripping and falling from a minor height or standing height. And when you have that with any sort of fracture, that itself is diagnostic of osteoporosis, where the bone is not strong enough to support what should be a daily part of life.
I understand that people don't know that they have those. How can that be?
Right. Oftentimes we see patients come in and they may have a new fracture, but they also have 3 or 4 older fractures that they never even knew about. And so a lot of these fractures, especially in the spine, are silent, and people don't know about them in both men and women.
Dr. Anderson, vertebral compression fractures are a problem for men and women, as Dr. Elder just said. How can we help patients understand knowing whether or not they have one of those that might be silent in their body?
The goals of bone health assessment is to find these occult spine fractures. And we now have newer technology that can be done at the time of bone density testing. It's called a vertebral fracture assessment, which is basically an x-ray of the entire spine where we are searching for these fractures, of which the majority are asymptomatic or occult, and people don't even know they had them. And they're oftentimes quite surprised when we tell them, and sometimes don't believe us till we show them the x-ray.
Wow.
That they have fractures in their spine that they don't remember, don't know about. It's hard to know because back pain is so common across the population that they may have had 3 or 4 days of back pain they've forgotten about, but it was from this fracture.
And other indications that we talk about in women is that they tend to lose height with age. Is that true for men also if they have a vertebral fracture?
Yeah, it's absolutely the same thing. There's really no difference between men and women.
So if you think you might be having fractures in there, if your height has decreased from year to year at your annual physical, you might think maybe I should check and see if something else is going on with my body.
Yeah, that's a very good point. Measuring height is a very simple test, safe, low cost. And the criteria is that if you have lost 4 centimeters of height from your maximum height, 4 centimeters is about 1.5 inches, or if you've lost 2 centimeters, which is like 3/4 of an inch since your last height measurement, that those are indications to have your bone density checked, because you may well have osteoporosis, you may well be sustaining these fractures, and like we said, some of them which are silent.
Yeah, that's so interesting. So we've talked about 2 kinds of scenarios where bone health is important as you think about your spine. There are fractures that can occur in your vertebrae, the vertebral fractures. And then there's the condition where you might be a surgical candidate. You might need surgery in your spine, a minimal surgery or a large surgery. Both of those situations, bone health is a consideration, and checking for your bone health is something you should talk about with your doctor. Let's talk a little bit about the scenario of finding out that you have a bone health problem or bone health disease. How do you approach treating that? Dr. Elder, I'm going to have you start off with that.
Right. So treatment is very similar between men and women. The first thing you want to make sure is that you've optimized any risk factors that you've had, whether it's smoking or alcoholism. You can't always change if you're on hydrosteroids for other medical issues. And then also looking at your calcium and vitamin D levels. The medications are largely similar. One class of medications is one that mimics estrogen, so that can really only be used in women that are perimenopausal. But bisphosphonates are one of the main class of therapy, and that's one of the best preventive strategies for someone who has been diagnosed with a fracture to prevent having an additional fracture. And that really has the same mechanism of action in both populations.
Dr. Anderson, there are some new medications that are available for patients.
Yeah. As alternatives to the bisphosphonates Dr. Elder discussed, are bone building drugs. And these are more powerful, they act more quickly, and they actually significantly increase your bone density far greater than the bisphosphonates will. And the name of these drugs are teriparatide, also known as Forteo, or abaloparatide, trade name is Tymlos. And these drugs are indicated people with severe osteoporosis, and really the ones we're talking about, people with acute hip or spine fractures, would be indicated for these drugs, or people who are about to undergo a higher risk spine surgery would also be indicated for these drugs. And these drugs work similar in men and women, although the bone builders are a little more effective in women than men, but not substantially so. There's a third drug out there called romosozumab, or also known as Evenity, but that drug is only approved in the United States in women and is not approved in men, so we wouldn't use that in the normal situation for men.
However, in some of our high-risk patients undergoing spine surgery, the mechanism of action of the drug should be the same, and we have used it off-label. And of course, I want to emphasize that it is off-label use of it by the FDA standard, but it can be used in men with similar efficacy.
Thank you so much, Dr. Anderson and Dr. Elder, for explaining those treatment modalities for osteoporosis. I think for many patients, understanding the appropriate treatment and when to have that treatment is very confusing and a little bit scary. The idea of my bones are weak and I need to take medicine to strengthen my bones we find a really difficult topic and a hard concept for people to understand. I think the comparison can be made to like high blood pressure, another silent disease. But once you find out that you have it, there are lots of different treatment options and lots of different ways to go about managing blood pressure. I think a similar analogy can be made for bone health. Many different reasons why you might have bone health problems. And there are lots of different ways of treating it depending on the needs that you have as a patient. How can you help patients allay their fear about side effects of some of these medications? So that's something that we hear a lot about. I'll let you start with that, Dr. Anderson.
Well, as with any medical treatment, there are risks and benefits. And these need to be explained to the patients of why a certain medication would be useful, what is it going to do that would benefit you, and what are potential side effects. And you have to remember, when we are talking about treatment of osteoporosis to prevent fractures, or in the case of spine surgery, bad surgical outcomes, which really mean you might have to go back and have a second surgery or a third surgery, these are substantial problems. And so the benefits are great. The risks of some of the side effects are generally can be mitigated or reduced with proper use of these medications and monitoring for side effects. And for instance, the bisphosphonates are associated with an increased risk of developing what's called an atypical femur fracture. But that occurs in one case for every 150 cases that it is prevented in. And since we're talking about men, women are much more likely to develop those complications than men are, as it turns out. So it's less likely to be developed in a man.
Dr. Elder, when you're talking with patients about treatment for osteoporosis, what are some of the topics that you cover when trying to help them understand why it's important to take the medicine?
Well, so I think in terms of preventing other fractures, I think that one's a little more straightforward because those obviously are a known risk to the patients. When we talk about spine surgery and how we're fixing things, at the end of the day, a lot of the surgery involves putting a screw into the bone. And if you think about putting a screw into the wall, if you put it into a piece of drywall, that's a whole lot different than putting it into a stud in the wall. And you get much better fixation if the bone is much stronger. Whereas if it's weak, there's a very high risk that bone will fracture, the screw is going to pull out. That can have significant side effects and often requires at least one or sometimes multiple additional surgeries.
And Dr. Elder, you've recently done some research on looking at spine surgery and osteoporosis and complications from that. Tell us about that study.
Right. Yeah. So we found that having osteoporosis is a very high risk factor for having complications related to your surgery. In some groups, depending on the severity of how weak the bone is, that can be up to 70% of the patients had complications. And treatment with some of the bone building medications that Dr. Anderson mentioned previously led to a significant reduction in those complications. And we found that the medication use has similar effects, at least looking at the spine, in both men and women.
So we've talked a lot today about men and bone health. We think about osteoporosis commonly as a disease that affects women, and it does affect women, a lot of women, but it also affects a lot of men. We've talked about 1 in 5 men have osteoporosis at various age brackets. Dr. Anderson, why aren't men getting diagnosed for osteoporosis more frequently?
Well, it's starts with primary care physicians also buy into the concept that this is screening for women. And in fact, most of the national guidelines are only applying to postmenopausal women. So we don't even actually have guidelines that recommend things for men. Also, there's an inherent bias by men, the patients themselves, thinking, hey, I'm a macho guy. I don't have osteoporosis. I'm not weak.
Right.
And so it's very hard to get men to buy into the concept that they have osteoporosis because in their mind, this is also a woman's disease, not a male's disease. So those are, I think, two major barriers.
Some biases that we have as healthcare providers and in the population. And we need to do more education because it's all about preventing fractures, right? And
yeah, I would say it's a harder sell in men to take medicine for osteoporosis than even women. I would say the other goal of treatment, and this is actually if you ask patients who just have sustained fractures, what do they want to get out of further treatment, is it's not so much to prevent another fracture, but it is really to maintain your independence. And if you have a hip fracture or soft spine fractures, your ultimate functional level is going to start deteriorating. And you get 2 or 3 of those, and you may end up in an assisted care facility, which pretty much nobody wants and is not a desirable outcome. And so the idea of using aggressive diagnosis and treatment in men is also to try to prevent loss of independence, even more so than fractures.
Yes, Dr. Anderson, that's so well stated, that ability to live independently as you age. And one of the things that we talk about is that aging is inevitable, but fractures don't have to be. And I think it's commonly thought out there that, well, as you get older, you break your bones. And so, Dr. Elder, I'd love for you to comment on that. How do men do when they're told that they get osteoporosis? And is fracturing your bones just a regular part of the aging process?
Well, it probably was in the past, but we definitely have ways to prevent it now. And I know we've discussed this in some of the series in the past, but really patient empowerment is what's critical in this. We've already spent a lot of time discussing that men are less likely to get diagnosed, probably less likely to even get tested, and maybe even less likely to get treated. And so really you have to empower yourself to talk with your primary